thank you, Professor Sammy and Professor Marcos, for giving me this opportunity. And I remember as a young faculty 25 years back that I was presenting in front of Professor Sammy at the Asian Oceanic meeting in Mumbai on my experience of cerebellopontine angle epidermoids. So I got this opportunity after 25 years. So I'm into epilepsy surgery, and I would focus on the strategies that we use in our setting. As you know, epilepsy is a psychosocial disease and a socio-economic problem. And here, the seizure burden, and the patient is intact, the seizure burden is high. So you cannot afford a deficit. And the patients who are suffering, this is the reason I'm talking about, that we have a population of 1.2 billion, and there are at least 5 million people with active epilepsy. And 25% of these are drug refractory, and there are at present 300,000 epilepsy candidates in India waiting for surgery. And at this moment of time, we are close to 500 to 1,000 surgeries being done per year. So you can, this is a well-established survey done by our very senior neurologist, Dr. Radhakrishnan, and it has been published in Neurology India. So with this burden, we cannot afford, we have to give them maximal seizure freedom, drug freedom, no deficit, and integrate them back into the society, because there is something like burden of normalcy. When these patients go back into the society with no seizures and maybe 1 or 2 drugs or no drugs, it is very difficult for them to face the society, because they don't get any more freebies. They have to integrate. So that is a tremendous burden. And obviously, it is a collaborative epilepsy surgery. It cannot occur as an individual surgeon. And this has been well documented by Penfield, Rasmussen's, and Jackson and Horsley's team. And here we have this 2,000-bedded hospital, KEM hospital in Mumbai. And our patients are not poor. They are poorest of the poor. And they are miserable. The family is miserable. It's not an individual. When we are talking about patients with tumor, it's the patient who is suffering with the tumor. But here is the family suffering on all fronts. So the responsibility is high on the surgeon and the collaborative team to give out maximal result. So we have new cases 70 per week, and the follow-up cases about 350 per week. And we try to, my talk echoes Professor Sammy's last 5 minutes talk that he gave, that about the cases that he showed about seizures, patient having seizures with focal deficits, and prevention of the seizure freedom that he mentioned. So we have this standard pre-surgical evaluation, and we maximize this evaluation. In India, we cannot afford to have stereo EEG and MEG and other modalities now and then, because they are very expensive, and they might or might not give you the final result after doing all those things. So we rely heavily on the standard pre-surgical evaluation that I've mentioned, and the surgical decision depends upon individual patient characteristics and patient's informed choice. So 22 years, we have 650 plus cases, and now it's about 700 cases, adult, pediatric, temporal, extratemporal. I have a long-term follow-up of more than 10 years of 200 patients, and the results have been extremely gratifying regarding seizure control, seizure freedom, and quality of life. Mind you, our threshold for surgery is very high, because we cannot afford to make any mistake in trying to increase our numbers and trying to get us optimal results, which will give a bad name to the program. This has been published, our all experience has been published in International Journal of Surgery, which has an impact factor of 14. So it is quite, our experience is published in these cases. So I would just go brief into the thing. So we all know that we are dealing with medial temporal lobe epilepsy and extratemporal epilepsy. I would focus more on medial temporal lobe epilepsy, and we need to know the functions of the hippocampus. It is more of episodic memory consolidation, and it is extremely important. So we need to know the hippocampal anatomy in detail, including subiculum, the hippocampus, the parahippocampal gyrus, and the fornix, and everything, and so on and so forth. Amygdala is no small structure. Amygdala has got 12 nuclei, and we cannot, as we know, we have to be very careful while excising the amygdala, because amygdala, it's an arbitrary line where we disconnect the amygdala from the mesial temporal lobe structures. Because if we go a little bit more medial, we might go into the basal ganglia, and the patient might have a deficit which may be difficult to recover. So apart from the emotions, the amygdala has a lot of functions about decision making, attention, memory, and it has role in vision, smell, hearing, and so on and so forth. So essentially, we are disconnecting the Papez circuit. So it involves emotion, memory, and seizures. So our epilepsy patient is fraught with not only seizures but the comorbidities of severe behavioral problems, psychiatric problems, which are have to be optimized before we take the patient for surgery. And this is what I mean, because all these patients we do they have multiple admissions in the ICUs, and there are a lot of socioeconomic issues, and we have to also understand the neuropsychological, the cognition, memory, and the intelligence. Obviously, everybody knows these two studies, the study from London, Ontario, and UCLA. So there is no doubt that epilepsy surgery has got its own role in giving seizure freedom. We have to do early surgery because we have to get the patient free of seizures, withdrawal of drugs, and the last two, sometimes these patients die suddenly. So SUDEP is a very well-known phenomenon, and as we mentioned, Professor Sammy's research about how the oscillations. There are these high frequency oscillations which causes depolarization, and sometimes when we are focusing on one side of the temporal lobe, the other temporal lobe may get kindled. So we have to emphasize the need for early surgery in these cases, because if we miss the bus, on one side we give 70% result seizure freedom. If you miss the bus, it straight away falls down to 50%, because the patient then becomes a bilateral MTS, and we have missed the bus. So we have to. The counseling part is also very important in our surgical program. So on this basis, I found a little bit different phenotype of mesial temporal lobe sclerosis seen in our country. Now, in the West, it is very well known that they do selective amygdalohypocampectomy. In India, in Indian conditions, it's not applicable. The reasons for it not being applicable is that we see a lot of, apart from the mesial temporal lobe epilepsy, we see a lot of lateral cortical neocortical epilepsy in addition. And also the temporal pole. The temporal pole is because of the continuous seizure, there is a gray-white blurring, you may call it, or it is dysplastic. So we find isolated MTS is very rare. Isolated MTS is always almost associated with a temporopolar type 1 dysplasia. And if we don't do a standard anterior temporal lobectomy, then we again are at loss. In India, no patients come for second surgery. So we have to do a single shot surgery, no stage surgery, and we have to do the complete job. So I would, at the outset, would say that we maximally use the non-invasive method of investigation, and we do a complete ATL. And on the right side, we are a little bit generous. If the right side, if we have to take out the hippocampus, we are a little bit generous, because we have found in our results that it doesn't matter that much in terms of the visual memory. And on the left side, we are obviously concerned because of the dominant lobe, because of the memory and the functioning level of the patient. Mind you, in India, we have these patients who maybe are high functioning executive, and it may be a homemaker who doesn't utilize that much of of memory. So the neuropsychologist comes very much important into the picture to give strategies to make the patient reinforce back into the society. So it's a game of all people working. So these in addition to the MTS that we see, I see a lot of these type 1 dysplasias in the temporal pole, and a diffuse kind of a picture. This is not described because in the literature you only see MTS, but there could be a diffuse cortical dysplasia. It's on one side. As I mentioned, there could be bilateral hippocampal sclerosis, or there could be an intensely sclerotic hippocampus unilaterally. So in dysplasia also, we have seen intra-hippocampal dysplasia. Again, you require a 3 Tesla radiologist, not a 3 Tesla machine necessarily. In fact, a good 1.5 Tesla machine with a 3 Tesla radiologist should be able to identify the intrahippocampal dysplasia on a 3D flare. So we have to have a good radiologist, a good neuropsychologist, an epileptologist who would guide the radiologist and the surgeon who is sitting at the back at the end to deliver the result. So and obviously the psychiatrist is also important person in this. So the whole program rests on this few people to give the maximal results. So mind you, my responsibility is not to give a deficit to the patient, do the complete job, because everybody is looking at us. Now this is FCD type 2 dysplasia. If you can see the mantle sign which is going right till the ventricle, it is very important that I follow with the intra-op electrocorticography right till the ventricle, because I've seen that if we fall short of the ventricle, the epilepsy may not subside. And periventricular tissue is very dysplastic. Periventricular tissue, because the neurons migrate from the ventricle to the surface, and since it is a migrational disorder, if we leave a portion of the neurons in the periventricular region, the epilepsy might come back in 5 years' time. So initially, you met a honeymoon period where the patient is a little bit seizures are reduced, blood drugs are withdrawn, but again, 5 years we can't accept. That's not acceptable. And I think it falls in line with Sir's psychology, where we have to see that we give them a long-term freedom. This is a case of insular dysplasia. I must tell you that this patient was having seizures, about 3 to 4 seizures per day. And I think it is very difficult to identify their dysplasia. It is along the left, the lip of the Sylvian fissure going into the insula. So obviously I used the intraoperative ECG, the monitoring, and I stopped at the posterior part of the insula because I got the INM motor, the MEPs dropped down. Now, having said that, I had to leave that part. I cannot give patient hemiparesis. And you can see here, the hand area was affected, so I had to stop. The ECG became silent. The patient became well. Now, I have on the post-op MRI, the residual insular dysplasia was seen. But mind you, the patient was well. The patient was, I knew that the patient is not, I've not treated the patient completely, but the patient was extremely gratifying. The seizures had gone, and in spite of all these things, I know that I've left because of the eloquent area, I've left it behind. The patient now is about 6 months down the line, is still not having seizures, but I'm sure, I don't know whether if the patient gets seizure again, whether I'll be able to go and excise that residual dysplastic tissue in the posterior insula. So we have already counseled them, but this is sometimes the limitation that we have, that in spite of having a good result, the surgeon may not be that much happy, and we have to accept sometimes. We have these special situations. Now, in India, you know, there are a lot of economic problems. So young women who are considering marriage, young women who get divorced, and sometimes the both sides, the husband and wife, the both parents want to come and get have the couple treated, because they don't want the people to get divorced. Pregnancy is another problem, because marriages occur early, so they want their girl or boy to get treated before they can get married. Pursuing higher studies, prerequisite. Sometimes it's a prerequisite for professional courses and higher executive functioning, that patients get treated for their epilepsy, and then only they can get their job.
So you have 1 minute.
1 minute. So I just mentioned this. I would skip this, and we use intra-op ECG in all patients, because we have found that it is not a predictor of seizure outcome, but it definitely helps us in getting a electrocorticographic silence. So we give the whole specimen is not in multiple pieces, but we have to give the entire specimen as a block. Otherwise, the pathologists do not understand what they are dealing with. So we have our share of problems. Sometimes in my early experience, I had 1 or 2 patients who had anterior coronary artery infarct, which again took 6 months to 8 months to recover. So surgery is safe, and I think we are in our patients. I would go, since there is a lot of time. Uh, this is our result ultimately with our 711 patients at the moment. And mind you, I wanted to share this last slide where we have done a with the International League of Epilepsy with the neuropsychological assessment. We have found that our patients do better as compared to the patients worldwide. And this has come, the initial ILE task force of neuropsychology was done in US, and Indian survey was done. The reason being in India, because it is plural, diverse, and patients are multilingual, each person knows at least 3 to 4 languages. And on these neurologic psychological testings, they do not show that those drop in scores, and they are better with strategies. So the reason I'm telling you, because there's a stark difference between, this has been published just 2024 in Epilepsy, and we are further evaluating it, that why our patients are doing a little bit well than the Western patients. Because 10-year seizure freedom rate in my patients is a little bit better than the Western population. It is about 58%. With this, I thank you. Thank you very much.